This week in Pediatric Oncology, the podcast exploring hot topics and exciting advances in childhood cancer. TWiPO is produced by Solving Kids Cancer, nonprofits located in New York and London dedicated to improving research and supporting families, because every kid deserves to grow up. Subscribe to TWiPO through your favorite podcast platform.
This week in Pediatric Oncology, the podcast about new advances for childhood cancer. Hi, everybody, and welcome to episode 107, recorded on December 20th, 2022, the last podcast of this calendar year. So we will see you or you'll hear from us in 2023 after this. I'm your co-host, Tim Cripe from Nationwide Children's Hospital in Columbus, Ohio, affiliated with The Ohio State University, but I'm flying solo today without my usual co-host as Dr. Weigel has a conflict today. But we have a special guest with us today who's been making the news media rounds from the results of his study, and that's Dr. Martin McCabe from the University of Manchester. Welcome, Martin, and thanks for being here.
My pleasure.
So just reading up a little bit about you, just a brief introduction. It seems like you got your Bachelor of Surgery and Medicine from the University of Cambridge. And then sometime later, about 14 years later, Doctor of Philosophy. So you must have been a glutton for more education. And now you're a clinical senior lecturer in pediatric, teenage, and young adult cancer in the Division of Cancer Sciences at the University of Manchester. Tell us about sort of what has driven you in your career and what your passion is at the moment.
So thanks for that introduction. On a clinical basis, I now look after adolescents and young adults, which in the UK means 16 to 24-year-olds with bone and soft tissue sarcomas and also with brain tumours. So I trained as a pediatric oncologist, but the job I ended up doing was really academic research with a clinical bent in young adults. And why did I choose to look after patients with bone tumours and brain cancers, which are really very different? The reason is because these are really the very poor prognosis diseases that are largely pediatric cancers in a young adult setting. So that's where we really need to make the most progress with changing what we do to improve survival.
Yeah, that's really fascinating. I agree with you. I tend to limit my practice to pediatric sarcoma patients, young adults as well, but not brain tumors. That's a whole different area, different sets of meetings, different kind of science behind them. So we have a whole different team. So how do you manage to keep up in both fields? That's a lot to keep track of.
Yeah, it's a challenge, I would say. It's a lot of hard work, but also very rewarding. I mean, I think one of the things I noticed working in really an adult setting, but looking after pediatric cancers, is that in pediatric oncology, there are some things that we view as very rare, like, hepatoblastoma or something where, a decent sized centre might see one patient a year or one every other year. Whereas something like adult medulloblastoma in an adult centre is viewed as very rare, but actually we see the same number of adults with medulloblastoma in an adult brain tumour setting as we do children with, alveolar rhabdomyoid sarcoma or atypical teratoid rhabdoid tumour, which are really viewed as just our bread and butter cancers. So, I'm a bit of an oddball because I'm a paediatrician working in an adult setting, but I'm viewed by my colleagues in my centre as the expert in all things pediatric brain, although, if I'm in a European brain tumour meeting, I really don't feel like an expert in those things. So it's all relative, I guess.
I think it's hard to keep up in any one field for sure these days. There's so much knowledge, explosion of knowledge and targeted therapies and everything else happening that I've found it to be an exciting time to be in any of these fields because there's so much discovery work going on. But yeah, it is hard to keep up. So yeah. It sounds like you're managing. How do you split your time then in terms of percentage time seeing patients versus either academic or committee work or administrative things?
Yeah, so half of my work is clinical, doing clinics, doing patient-related admin, and just a bit less than half is clinical and just a bit more than half is research. And that research is a mix of the clinical trials that I'll be talking about today, plus a bit of epidemiological work. So I work with the English National Cancer Registry for children and young people, which is a really fascinating area of data. And of course, as we cure more and more patients, it means that it's harder to, or that there are fewer and fewer clinical trials to put our patients into with good prognosis tumors. So the observational data that we can get from registries becomes more and more important. So that's very interesting. And then I do collaborative work with lab-based scientists, really doing translational work, trying to get the biology that we understand from preclinical models into the patients that we're treating in clinic.
Yeah, it's really important to be able to do that. And there's that valley of death, they call it, between the lab and the clinic, all the different regulatory steps and data that's needed and effort that it takes to launch trials. So it's important we have people like you in there doing that work and getting things to the clinic. Tell us about, we wanted to sort of focus today a little bit on the rEECur trial that you ran and have recently presented at the American Society of Clinical Oncology meeting. Tell us about the genesis of that, sort of the idea originally, and what led to it.
Yeah, so what led to it, as with a lot of these things, was actually a conversation at a railway station with a colleague, Jeremy Whelan, who's very well known to the sarcoma community, about how do we treat patients with relapsed Ewing's. And of course, in common with a lot of relapsed pediatric cancers, the evidence base that we use as our basis for all of the decision making is very weak. And so, in fact, when we looked at relapsed Ewing's, there'd been no randomized trials. We were basing treatment on very small numbers of published patients. So frequently, for something like gemcitabine docetaxel, which is one of the rEECur regimens, that was a regimen that was particularly favored in Spain when we talked to European colleagues, but actually the number of children or adults who'd been treated with gemcitabine Taxol was very small, and it was made up of lots of different series, each of which might have had 2 or 3 or 4 patients in. So the evidence base was just incredibly tenuous, and we thought, there's an opportunity to do something here. Everybody who looks after Ewing sarcoma, nobody had the answer. There were actually some surprisingly strong opinions about how we should treat relapsed Ewing's, given the lack of evidence. But what we all really wanted was better evidence. So it was actually very easy to bring a trial together. It was precipitated actually around a European discussion that we had about PARP inhibitors on the basis of a paper that was published in Nature just 10 years ago now, showing preclinical evidence for PARP inhibitors. And that hasn't yet translated into great clinical activity, as you know. But it brought that sort of brought together a meeting of a lot of Ewing sarcoma people around Europe, and it was an opportunity to get together and say, look, we've got this idea that we'd like to do a study. What do you think? And that really was the start of the whole process.
Well, that is, you bring up such a great point that we need evidence, and we often don't have it, so we rely on anecdotal evidence or our own personal experience, and it may not be based in fact. It may be quite biased, and sometimes it's difficult to go back and test regimens that have been around a long time and say, how do they really work? So, did you have trouble sort of coming up with which regimens to compare in this trial, or was it pretty obvious? And were you worried about accrual?
So we were certainly worried about accrual, yeah. I would say the regimen that everybody was using first was irinotecan temozolomide. It was everybody's favourite. We did a formal survey around the UK, but just a straw poll of European colleagues said the same thing, and I know the same was true in the States. So we were all using irinotecan temozolomide, but we were all using slightly different versions of it, and most of us were using versions that had not been published in children, with Ewing sarcoma at least. And then the second commonest regimen was the topotecan cyclophosphamide regimen. And initially the discussion was just doing a randomized head-to-head comparison with those regimens. But then when we got together as a European group and said, look, it's going to be quite a lot of effort to open this trial. Are there other regimens that we think we should be evaluating? And then we picked the Gem-Taxol regimen because it was in use quite widely. And then a lot of people were also using high-dose ifosfamide in a variety of settings. So sometimes on its own, sometimes with other drugs as part of ICE or VIP or one of those things. And when we estimated the number of patients, we thought we would probably be able to get away with a 4-way randomization, but probably no more arms than that. There were other contenders. So actually, even at the outset, the carboplatin etoposide arm that's currently in rEECur was also a contender, but we felt the evidence, it was more of a newcomer, the evidence was weaker, and so we picked the 4 initial regimens to start with. And when we were setting up the study, even just among ourselves, but then when we presented it to various scientific groups, there was quite a lot of pushback about doing such a complicated study in a rare disease. And there was some suggestion that we should just simplify it and do a 2-arm comparison between irinotecan temozolomide and topocyclo. But we sort of pushed back against that and said, well, look, this is a once in a lifetime chance to evaluate these regimens. Let's get as much out of it as we possibly can. And we were certainly worried about accrual. So actually, when we were designing the study, it wasn't the cleanest design because we wanted to get as many patients as we possibly could. So, for instance, we described in the protocol the first 4 or 6 cycles of chemotherapy. And then after that, it was investigators had free rein to do local control, surgery, radiotherapy, high dose therapy, give more chemotherapy if they want, switch regimen, all sorts of things, which means that the data coming back is not that clean, but it is clean for the first 6 cycles. And of course, unfortunately, event-free survival is not great in this disease. So by the time you've had 6 cycles, a lot of people are already progressing anyway.
Yeah, that's right. It's been quite a big challenge to relapse Ewing's. Did you have trouble getting investigators to agree to the exact same regimen if there was such differences in clinical practice in terms of doses and administration and that sort of thing?
So you get 10 clinicians in a room and there's 10 different opinions of what we should be doing, as you well know. The topocyclo regimen was easy because we were pretty much all using the same one. The rest, we got there through negotiation and we all wanted this to work. So it wasn't terribly difficult, but we worked sort of on the basis that these are cytotoxic chemotherapy drugs. So we're not looking necessarily for biological activity. The population we're getting them to is by and large young and therefore able to tolerate quite intensive chemotherapy. So we thought, let's give these regimens the best chance and use the highest doses that are either published or that we're all using. So the irinotecan temozolomide regimen, of course, everything that had been published in Ewing's used the low dose protracted, either 1 or 2 weeks of low dose irinotecan. But in practice, a lot of people had moved over to a higher dose regimen, which was also in use in rhabdo and neuroblastoma. So we chose that 50 milligram per meter squared daily of irinotecan temozolomide. And actually in CTOS, I noticed there was a poster there suggesting that we should go back to the low dose regimen, which we can't do now. But it's still an open question that, we don't really know what the best regimens are. For the gemtaxol regimen, again, I was pushing for higher doses. There was a bit of negotiation and anxiety that our adult colleagues hadn't used higher doses of gemcitabine or docetaxel. So we ended up having a bit of a sort of medium dose. In fact, as it turned out, the toxicity for the gemtaxol arm was less than for any other arm. So we probably could have pushed the dose up, but you don't know these things in advance. So there's a bit of negotiation, I must say, but it was agreed pretty quickly.
Yeah. Well, it seems like there are a number of groundbreaking features of this trial. One is getting people to agree. Another is, going back to tried and true medicines that we think have activity and then, getting people to randomize on them because there's so many, these drug combinations have been around so long. Everyone has their own biases we talked about and preferences. So to get them to agree to randomization is probably another big win that you had. What other challenges were there in setting it up, or was it pretty straightforward after you came to an agreement about the regimens?
So we were very lucky, actually, in our timing that there was a European Union grant. This is in the good old days when the UK was still part of the European Union, so we could apply for funding. I shouldn't really go into that in too much detail, but there was a source of funding that would allow us to run a European trial. So we put a proposal together that had the rEECur trial, but also the first-line trial and biological studies work packages and various other things. And that we were very lucky to get that. And I think without that, we would have struggled to get an international study open. The major hurdle actually in the beginning was just all the regulatory things, the regulatory hurdles that had to be gone through. So at least in every country, we had to get competent authority and ethics approval. In some countries, every hospital had to get its own ethical approval. And there were, every competent authority, every ethics committee had quibbles about the protocol, which delayed opening, but didn't at any point fundamentally change the trial design or what we plan to do. But it's a lot of time and effort and a lot of delay without actually any meaningful change to the protocol, which is, this isn't news to anybody who tries to open a study, but it's frustrating. So, it took several years for some countries to open. And actually one country of the initial planned countries is still not quite opened. So that was frustrating. I would say other than that, because this was a trial that everybody wanted to do, the main challenge is the rarity of the patients. But we actually recruited, until COVID struck, we recruited consistently very well. Because there was nothing else for these patients to do. So everybody was, although it's a sort of boring chemotherapy question, people were happy to put their patients into it because we all wanted more information at the end of the day. COVID was a challenge, but we actually, at the peak, we were recruiting 6 to 8 patients a month. Even during COVID, we were recruiting 2 to 3 because patients still need to be treated. And so there's nothing very difficult about this study because it's really standard of care with a bit of biological sample collection and quality of life questionnaires. So we actually did continue to recruit. And as some countries were coming down with COVID, other countries were recovering. So it didn't really stop completely. And since then, it's improved again.
Oh, that's great. I mean, it does take so long to get these things done, and everyone wants to have their own say. And when they evaluate these, every committee, it does cause unnecessary delays, I think. Is this a trial that you think, since you guys are no longer part of the UK, you would have a more difficult time now getting done? Or is it just, if the funding aside, if you had the funding, are the regulatory burdens even more so now?
I think the regulatory burdens they will always be there. They're different. I think, we all follow the same European laws, but every country interprets those laws quite differently. And, I think so I think whenever you try to open a study, it's going to be pretty similar.
Yeah, I guess we still got to keep pushing. So let's get into the results a bit. Yeah, I know you reported them. I don't know if you have any updates since then, but tell us the basics. How many patients did you accrue and what did you find?
So overall, we've recruited more than 500 patients now. The study is actually still open. So it's an adaptive design, multi-arm, multi-stage design. So the idea of that is we wanted a design that was as efficient as possible. We wanted the flexibility to be able to drop ineffective arms quickly. And then as new or interesting drugs or regimens came up, we wanted to bring them in as soon as we could, really. So we dropped the first arm, which was the gemtaxel arm, in late 2018. We presented that in ASCO 2019. And that was on the basis of worse imaging response, which was initially our primary outcome measure, and also worse EFS and overall survival. We dropped the irinotecan temozolomide arm a year later, and we presented that in 2020. And I would say that was probably the most difficult point in the study because it was everybody's favorite regimen. There was a lot of surprise that it was dropping out. And in retrospect, actually, now that we have unblinded data for all the comparisons, there's very little difference between irinotecan temozolomide and topocyclo, and arguably, therefore, with not that much difference with ifosfamide. But the rules that we set were that we would drop an arm and then we would drop a second arm, however little the difference was between that arm and the next best arm. And that was just on the basis that we're dealing with a very rare cancer. We couldn't carry on a 4 or 3-way randomization for years and years. It would be too boring, and we wanted the trial to be more agile than that. So we dropped the irinotecan temozolomide arm, again on the basis of worse imaging response, which was still the primary outcome measure at that time, and also worse EFS. But there was very little difference. And although the arms were still blinded at the time, we could tell from the probability that irinotecan temozolomide was worse, that there'd been a big probability that gemcitabine docetaxel was worse. There's a much smaller probability that irinotecan temozolomide was worse. And then we did the phase 3 comparison between topocyclo and ifosfamide, which we presented at ASCO earlier this year. And in terms of results, there was a 2-month difference in the median event-free survival. And we'd always planned that event-free survival would be the primary outcome measure for the phase 3 comparison. So that was a difference between 3.5 and 5.7 months, with ifosfamide being better. And in terms of overall survival, there was a 10% difference in 1 year and 2 year overall survival. So a difference between 37 and 47%. Is that? No, sorry, that's 6-month EFS. The difference in overall survival was between 45 and 55% in 1 year. So, we were surprised that the phase 3 comparison was done so early. We'd modeled initially that we would need at least 200 patients in each of the phase 3 arms to get any sort of confidence of a difference in outcome. But with only 73 patients in each arm, the data monitoring committee recommended that we close the randomization because they had obviously been watching this trend for a while, and they thought we couldn't justify continuing to randomize patients if there was a 10% difference in the proportion who were still alive a year later. So on that basis, we closed the topocyclo arm, and we'd already brought in a carboplatin etoposide arm. So the trial is currently comparing high-dose ifosfamide and carboplatin etoposide. And we are hoping to bring in an ifosfamide with lenvatinib arm early in the new year. So that's just going through regulatory work now. And that's very exciting for us, of course, because it's the first molecularly targeted therapy in the study. So, I guess the most recent data that we presented was at CTOS in Vancouver a couple of weeks ago. And that was, we had an oral presentation of all of the multiple pairwise comparisons, because that hadn't been presented previously, and a poster of the overall prognostic factors for the whole trial cohort. So, I think one of the real successes of this study is that because of the design, rather than just having a two-way comparison, we've done so far 6 pairwise comparisons. So each possible pairwise comparison between the different 4 arms. And that means, of course, that we've got a lot more comparative information. Now, because of the way the randomizations happened, some of those comparisons have a lot more patients in. So the biggest one was between irinotecan temozolomide topocyclo, and that had 115 patients in each arm. And it showed that topocyclo was better. The hazard ratio favored topocyclo, but not by a great deal. And when you look at the survival curves, they're pretty close together. The biggest difference was between gemcitabine docetaxel and all of the other arms, and there was a very clear difference that gemcitabine docetaxel was worse in every case, and then the phase 3 comparison that we presented at ASCO. And unfortunately, because of the way the randomization worked, some of the comparisons had very few patients in. So the comparison between ifos and gemtaxel and between ifos and irinotecan temozolomide, really, they had too few patients in to say anything convincing about the results. So they are really still unanswered questions. But, I would say there's convincing evidence that gemcitabine docetaxel is worst. There's convincing evidence that irinotecan temozolomide topocyclo are quite similar, but topocyclo just pips it in terms of survival, and convincing evidence that ifos is better than topocyclo. So we do have a sort of gradation. But even then, the 3 best arms, they're not that dissimilar. And although ifosfamide is better, of course, it comes with some toxicity. So that there is a small proportion of patients who had acute renal toxicity, and not unexpectedly, there were 7% of patients who had encephalopathy, which is something that we didn't see in any of the other arms. On the other hand, and actually comparing toxicity is another really important outcome for the study. So irinotecan temozolomide patients had a significant gastrointestinal toxicity. Again, none of this is new, but 25% of them had grade 3 diarrhea. So that's 7 stools a day, which is, for a disease that's very poor prognosis, where most people, when they start treatment, are in the last few months of life, probably. To be confined to the house with 7 diarrheas a day, that's pretty toxic. And it's not something that, as hospital doctors, we necessarily see, because the patients don't come in with it. They just stay at home, and it's pretty awful. The 2 phase 3 regimens, so topocyclo and ifosfamide, were both significantly more toxic than the other regimens. in terms of myelosuppression. And again, that's not a surprise, but one of the nice things about having head-to-head comparison was, for instance, to see that actually topocyclo is as toxic as ifosfamide from a febrile neutropenia point of view. And when we look at the whole cohort, there were more patients had febrile neutropenia and topocyclo than in any other arm. So, we've got unfortunately, we haven't got any actual papers out, although we've presented the trial in numerous venues. But I think when we get the papers out, which will hopefully be soon, there is a lot of really good and important efficacy, but also toxicity data that we all as a community need.
No, it seems like a lot of great information for clinicians. One of the questions I'm thinking about is, were some of these toxicities cumulative? In other words, especially, for example, the renal toxicity with ifos, and such that perhaps if you were to design a regimen where you were alternating these, because it sounds like all the different regimens had activity, some were better than others. So could you sort of milk them for what they're worth, by have you thought about alternating them in cycles in the same patient over time, and thus delaying some of those cumulative toxicities?
Yeah, that's a really good question, to which I don't have an answer, I'm afraid. Some of them were certainly cumulative, but not all of them. And actually, even, I think one of the issues that we came across is because we called high-dose ifosfamide high dose, you weren't allowed in the protocol to have a dose reduction. So if you had the predefined toxicity, you had to stop ifosfamide, at least in terms of the trial. But actually, I know that there are some patients who had to stop because of, electrolyte loss or whatever, that met the trial thresholds, but their clinicians carried on giving it to them anyway, or they carried on giving it at a slightly reduced dose, although that wasn't allowed in the protocol. Whereas the other regimens, there were dose reduction written in, so a lot of those patients carried on. So artifactually, it looked as though, well, not just it looked as though, there were a lot more patients on ifosfamide who stopped early due to toxicity, but I know from correspondence and from the CRFs that we've collected that a lot of those patients actually carried on having treatment. But it's a really good question as to whether we should have a regimen that alternates different chemotherapy to, as you say, change the toxicities and hopefully make the cumulative toxicity less.
We're almost out of time, but I wanted to talk a little bit more about the future. Well, one thing I will say is it feels like you went through a lot of work to get this open in a lot of different countries. And it was a lot of effort, but you've actually leveraged that by being able to adapt the protocol and continue it and add, drop lines and add cohorts and so forth. So that's exciting, because then you can just keep the research going without having to stop and restart with a new protocol every time. So congratulations on that. We do anticipate getting these, having you publish this results so that the information can be more widespread. But what the future of it, do you anticipate, because you mentioned adding a molecularly targeted agent, can you talk about that in particular? And do you anticipate sort of continuing this iterative, adaptive part into the foreseeable future as new ideas come along?
That was certainly the plan from the outset, and we are keeping our ear to the ground about other classes of drugs of interest. So the TKIs are really the closest to the clinic, which is why they're the easiest to bring in. But there are, there's PARP inhibitors that have struggled with chemotherapy, but there's still a rationale why they should be effective. mTOR inhibitors, CDK inhibitors, LSD1 inhibitors. There's various drugs that we're interested in that we'd like to bring in. Within the trial management group, we've agreed a set of criteria that we think arms should meet to be considered, high among which is industry buy-in, because of course without industry support we can't afford to use these drugs because they're pretty much uniformly very expensive. And we're lucky that we have support to bring in lenvatinib. That was very much our desire, just because we know how long it takes to open any study in a rare cancer like this, where you need to have many countries and centres open. And it's very inefficient to just do a small comparison, drop the study, then start from scratch with a new study. So it is absolutely our desire to keep bringing in new arms and evaluating them. But that's difficult because now that the European funding has ended, every country is now scrabbling to get its own funding. And so far we've been successful for most countries, although some have had to drop out, unfortunately. But national funders don't really like funding a trial that's already open. Everybody wants something shiny and new. And so, I think the longer the study stays open, the more difficult it will be to get national funding for it. But so far, fingers crossed, we've been lucky.
And mostly it's in Europe and Australia, is that right? No sites in the US.
We have tried several times to open in the US, but there are some challenges.
Yeah. Well, I think it's really important work, and we appreciate your efforts on this behalf and on the behalf of all of our patients. And hopefully, as you publish the results and continue to present them at meetings, we can adopt some of the findings. And one last question I did want to ask: have you thought, since our initial Ewing's is interval compressed chemo, have you thought about doing any other modifications of these traditional regimens, such as interval compression?
So we haven't actually in rEECur. That's a good question. There are only so many questions you can answer. That's the problem, And I think, with ifosfamide being the winner, I've had a lot of conversations with various people about using the 14-day ifosfamide regimen, which anecdotally is much kinder. Certainly, we've used it in my centre, and others have used it, and it seems to be less toxic. But I don't think it's safe for us to assume because high-dose ifosfamide in this regimen is better than the other regimens, or albeit marginally, that any other high-dose regimen will be as effective. And I think, my main message from this to everyone is that it's not impossible to do important trials in rare cancers. You just have to collaborate widely. And I think if there's a desire to, for instance, test the 14-day ifosfamide regimen, or as you say, to alternate high-dose ifosfamide with other regimens, we should do that, but we should do it in a controlled way in a trial, not just do it because it seems like a good idea.
Yeah, well, I think that's probably one of the main lessons your study has shown, because everybody thought they had good ideas, and those got peeled away one by one, it sounds like. So.
And actually, the question I would really like to examine in this study is a randomized question about high-dose therapy, because of there's so much observational data now that patients with relapsed Ewing's who have high-dose therapy do better. And of course, there's the question is, do they do better because it's the good players who then get high-dose therapy? And we'll never know that without doing a randomized trial. It's something that we discuss occasionally in the trial management group, but I think that is something that really needs a randomized trial to ask a question. The problem there is defining the right patient group to do it in.
I keep trying to sneak in one last question. How did you blind it? If these are different regimens, people know what they're getting.
It wasn't blinded.
Okay.
Yeah.
I thought you said there was blinding. Okay, perfect. All right. Well, that's great. Thank you so much for being here. Thank you so much for sharing your study, trial, tribulations, results, and ongoing efforts with us. And we wish you the best of luck as you move forward.
Thank you very much. And it's been a pleasure.
So also thanks to the team at Solving Kids Cancer, a nonprofit charity dedicated to improving survival through creating novel treatment options for children. Remember, the more we learn, communicate, share ideas, and work together, the faster we'll reach the day when all childhood cancer is preventable or curable. As always, keep with the fight, and thanks for listening to This Week in Pediatric Oncology.
We welcome your comments, questions, or thoughts on topics for future episodes. Just drop us a note at TWiPO@solvingkidscancer.org. You can follow Dr. Cripe on Twitter at KidsOncDoc. Send an email to Dr. Weigel at weige007@umn.edu, and find all TWiPO episodes at solvingkidscancer.org.